So, now we will talk about the patient with a reaction stressful to a stressful event. Okay, let's start. It is normal to have some psychological symptoms after a stressful event or bereavement. However, in some cases, these symptoms may be more severe than expected and impact upon everyday functioning. It is important to be able to distinguish a normal reaction to a difficult life event from a specific constellation of symptoms that denote psychopathology requiring clinical attention. So let's start to talk about definitions and clinical features. When assessing someone who may have had a pathological response to a stressful event, it's important to explore two variables: the nature and severity of the life event and the nature and severity of the person's reaction to the life event. So let's talk about nature and severity of the life event. Stress. Psychosocial stressors is the term used for any life event, condition, or circumstance that places a strain on a person's current coping skills. It is important to remember that what constitutes a stressor is subjective and dependent on the specific person's ability to adapt or respond to a specific challenge. For example, one student may breeze through an exam without experiencing any stress, whereas another may feel incredibly strained because of a perceived or actual mismatch between their ability and the demands of the situation. Also, note that the same person's coping skills vary throughout their developmental life. The death of a distant relative may be far more stressful for a middle aged man com- um, contemplating his own mortality than for an invincible adolescent. Communication tip. Whenever a patient presents with low mood or anxiety, always check for possible psychosocial stressors and establish how, if at all, they relate to the onset of symptoms. If the stressor seemed insignificant, verify how it was perceived by the patient. Remember, a seemingly innocuous life event may be a significant psychosocial stressor for a vulnerable patient, like a change of accommodation for an elderly widow. About traumatic stress. A traumatic stress occurs outside the range of normal human experience, and its magnitude means that it would be experienced as traumatic by most people. This type of stress occurs in situations where a person feels that their own or a loved one's physical or psychological integrity is under serious threat. These include natural disasters, physical or sexual assaults, serious road traffic accidents, terrorist attacks, torture, and military combat. Bereavement is a special case of traumatic stress that will be discussed later. So, we've talked about the nature and the severity of the stressful event. What about the nature and the severity of patients' reaction? Some people seem to experience stressful or traumatic life events with minimal symptoms, while others seem more susceptible to developing a pathological response. Depending on the severity of the stressor and the person's underlying vulnerability, a patient may develop an adjustment disorder, an acute stress reaction, or post traumatic stress disorder, a dissociative disorder, or another major mental illness such as a depressive, anxiety, or psychotic disorder. Let's talk about these differentials, starting from adjustment disorder. Feeling unable to cope is common at times of psychosocial stressors to which we need to adapt or adjust, such as moving house, um, moving house, changing job, or becoming a parent. However, When symptoms are considered significant enough to be out of proportion to the original stressors or cause disturbance of social or occupational functioning, this can be described as an adjustment disorder. For this diagnosis to be made, the emotional and or behavioral symptoms need to occur within 3 months, according to the Diagnostic and Statistical Manual of Mental Disorders. Again, so for this diagnosis to be made, the emotional or behavioral symptoms need to occur within 3 months, according to DSM. Okay, and ICD. Okay. ICD-10 states 1 month of original stressor. So this is some difference between DSM, which may need 3 months to diagnose this patient, and ICD it is 1 month. ICD-10, of course. Although it is assumed that the disorder would not have arisen without the original stressor, an individual's personality and vulnerability to stress play an important contributing role. Okay. Symptoms usually fully resolve within 6 months of onset, and if this is not the case, consideration should be given to a different diagnosis. Okay. Usually, adjustment disorder is characterized by mood and or anxiety symptoms, and this can occasionally be of severity sufficient to cause disturbance of conduct, like reckless driving, aggressive behavior, and so on. Many people with adjustment disorder also experience suicidal ideation. Hints and tips. You should only diagnose an adjustment disorder when patients do not meet the criteria for a more specific diagnosis, such as mood, psychotic, or anxiety disorder, including post-traumatic stress disorder, or a normal bereavement reaction. Another differential here is acute stress reaction. The symptoms of an acute stress reaction develop immediately after or within a few minutes of a traumatic stressor. Typically, sufferers will experience an initial dazed state followed by possible disorientation and a narrowing of attention with inability to process external stimuli. In some cases, this may be followed either by a period of diminished responsiveness to the extreme of a dissociative stupor or psychomotor agitation and overactivity. Patients may also have amnesia for the episode. These symptoms normally begin to diminish after 24 to 48 hours and are usually minimal after 3 days. Because this diagnosis describes symptoms which are part of the spectrum of normal existence and do not require any specific treatment, this diagnosis is little used and is undergoing revision in psychiatric classification systems. DSM-5 now specifies that an acute stress reaction should only be diagnosed if symptoms persist for longer than 3 days, and at the time of writing, the latest draft of ICD-11 no longer lists it as a mental disorder. Okay. So this is acute stress reaction. In DSM-5 we have acute stress disorder for more than 3 days but less than 1 month. What about post-traumatic stress disorder? The symptoms of PTSD usually develop after 1 month, but within 6 months of a traumatic stressor and lead to significant stress or functional impairment. Symptoms include all of the following. 1. Repetitive experiencing of the traumatic event in the form of, we will talk about that, but let's list the main symptoms. We have repetitive experiencing, or what we call intrusive symptoms, avoidance of stimuli, increase in arousal. So about the repetitive re-experiencing, this would be like flashbacks, intrusive, unwanted memories, vivid mental images, or dreams of the original experience. or as a form of distress caused by internal or external cues that resemble the stressors. At times, patients may dissociate and experience the original event as though it were happening at that moment. Our patients may also experience hallucinations and delusions. The second thing is avoidance of stimuli associated with the stressor. Amnesia for aspects of the trauma, as well as emotional numbness and social withdrawal. An increase in arousal like insomnia, angry outbursts, hypervigilance, poor concentration, and exaggerated startle response. The biggest risk factor for post-traumatic stress disorder is experience of past trauma, particularly during childhood. The latest draft of ICD-11, not yet published, includes the diagnosis of complex post-traumatic stress disorder, where people who experience a series of severe traumas, like repeated childhood sexual abuse, develop persistent difficulties in regulating affect, relationships with others, and feelings of worthlessness, guilt, and shame. These symptoms are closely related to those seen in reactive attachment disorder in childhood. Reactive attachment disorder and emotionally unstable personality disorder. Okay, of course, yeah. So, here we have a red flag. When assessing a patient with suspected post-traumatic stress disorder, remember that head injuries and epilepsy are important differential diagnoses, and that may present with similar symptoms and may also have been caused by initial trauma. Patients with PTSD also have a high rate of comorbid substance misuse, and it is also important to be vigilant for symptoms of alcohol or drug intoxication or withdrawal. Communication. Not everyone who tells you they are traumatized has post-traumatic stress disorder. PTSD is only diagnosed following an event which the majority of people would experience as life-threatening or catastrophic to themselves or to loved ones. For example, severe domestic violence rather than a relationship breakup. Okay, another differential is dissociation. In psychiatry, dissociation describes a disturbance in the usually integrated functions of consciousness and cognitions. In this phenomenon, memories of the past, awareness of identity, thoughts, emotions, movement, sensation, and or control of behavior become separated from the rest of the individual's personality, such that they function independently and are not under voluntary control. Here we have a box that describes the more common dissociative disorders. Okay, we'll talk about that. Hints and tips. Depersonalization is feeling yourself to be strange or unreal. Derealization is feeling that external reality is strange or unreal. These can be considered as types of dissociation and may be caused by psychiatric illness, like depression, anxiety, or schizophrenia, or physical illness like epilepsy, or psychosocial stress and substance abuse. Dissociative disorders are not well understood and are undergoing revision in classification. The ICD-10 requires that there be some evidence of a psychological causation, like stressful event or disturbed relationship in association with the onset of the dissociative symptoms. However, this requirement is absent from the current draft of ICD-11. DSM-5 classifies the memory symptoms in the table as dissociative disorders and the neurological symptoms as somatic disorders. We'll continue that. Let's get back to the differential diagnosis for persistent presenting with reaction to stress. This is another thing, but here we have some differentials for patients presenting with a reaction to stress or trauma, like adjustment disorder, post-traumatic stress, acute stress, normal bereavement, dissociation, exacerbation or precipitation of other psychiatric illness like mood, anxiety, or psychotic disorders, or even malingering. But that's not the... Okay, where's the... we are looking for table. Okay. Here we have dissociation causing neurological symptoms. This is functional neurological symptoms. We have dissociation causing memory symptoms and less common dissociative disorders. Okay. For dissociation causing neurological symptoms or functional neurological symptoms, we have dissociative anesthesia and sensory loss. So these functional neurological symptoms, they are called conversion disorder in DSM-5. These include dissociative anesthesia and sensory loss, as we said. So we have continuous or visual sensory loss that does not correspond to anatomic dermatomes or non-neurological patterns. We have dissociative motor disorders, which may be something like partial or complete paralysis of one or more muscle groups, and not due to any physical illness or physical cause. And we have dissociative convulsions, or what we call psychogenic non-epileptic seizure, used to be known as pseudo seizures. However, the name has been changed because of concerns that the term pseudo implies a degree of voluntary control, which is not the case here. May present similarly to epileptic seizures, but tongue biting, serious injury, and urinary incontinence are uncommon. There is also absence of epileptic activity on the EEG. So, another kind of dissociation causing memory symptoms like dissociative amnesia and dissociative fugue. For dissociative amnesia, there would be partial or complete memory loss for events of a traumatic or stressful nature, and these are not due to normal forgetfulness or organic brain disorders or intoxication. Dissociative fugue, rare disorder characterized by amnesia for personal identity, including memories and personality. Self-care and social interaction are maintained, usually short-lived hours to days, but can last longer. Very often involves seemingly purposeful travel beyond the individual's usual range, and in some cases, a new identity may be assumed. And in DSM-5, it is a specification for dissociative amnesia in dissociative disorders, within dissociative disorders. So less common dissociative disorders like dissociative stupor, trance, or dissociative identity disorder, multiple personality disorder we call it. So for dissociative stupor or trance, severe psychomotor retardation characterized by extreme unresponsiveness, lack of voluntary movement, and mutism, not due to physical or psychiatric disorder, that is not due to depressive, manic, or catatonic stupor. Another one is dissociative identity disorder, which is multiple personality disorder. There would be apparent existence of two or more personalities within the same individual. This is a rare and highly controversial diagnosis, of course. Okay, let's continue with the text. The shifting classification system reflects shifts in understanding of the causes of these syndromes. They are now falling more under the umbrella of medically unexplained symptoms and of functional symptoms. This is in ICD-10. It is now thought that dysfunction in high-level cortical processing of motor and sensory information can lead to symptoms which are genuinely experienced, involuntary, and not necessarily related to past or current trauma, even though no structural or physiological abnormalities is identified. Older terms such as hysteria and conversion disorder are now little used, as they imply a psychogenic causation which is now in doubt. Actually, conversion disorder is still in DSM-5. Okay, I don't know about ICD-11. Dissociative disorders should not be diagnosed if there is evidence of physical or psychiatric disorder that plausibly explains these symptoms. In addition to assessing for evidence of known physical disorders, it is also useful to check for positive signs of functional neurological disorder. So, If present, this strengthens the evidence for functional or dissociative neurological condition. However, if in doubt, it is safest to ask a neurologist for their opinion too. Here we have some positive signs of functional neurological disorder. The first is functional seizure or dissociative convulsion. Signs like eyes shut, resisting, opening, ictal or post-ictal weeping, long duration, memory of ictal events like I was shaking all over and so on. For functional paresis or dissociative motor disorder, there would be Hoover sign, a give way quality to the weakness, a limb that when left suspended in the air hovers for a moment before folding. So, okay. Another thing is functional sensory loss, like dissociative anesthesia. Neurodevelopmental pattern of sensory loss, like sensory abnormalities that stop at the groin or shoulder. Okay, this is okay. Functional tremor, entrainment, the tremor frequency aligns with that of a voluntary rhythmic movement, stops with distraction, this is called mental arithmetic, and worsens when attempts to made to immobilize if limb held into by examiner. So these are some signs that may indicate functional neurological disorder other than, somatic. Okay, here we have a red flag. Before accepting the diagnosis of dissociative disorder, a neurological or other psychiatric disorder should be carefully sought by and adequately excluded, of course. Okay, although dissociative disorders are covered in this chapter, around 1 in 3 functional neurological disorders arise in the absence of a stressor. Hints and tips. The Hoover sign is weakness of hip extension, which turns to normal with collateral hip flexion against resistance. This can be demonstrated to the patient to reassure them that is a problem with muscle control, not structure, which is causing their leg weakness. What about precipitation or exacerbation of an existing mental illness? The influence of patients' environment on their mental health cannot be overemphasized. Almost all forms of mental illness, like depression, psychotic illness, or anxiety, can be precipitated or exacerbated by psychosocial life events or traumatic stressors. However, unlike the above reactions in this group, there need not to be a direct etiological link with the stressor involved. What about bereavement? Bereavement is a unique kind of stress experienced by most people during their life and is a normal human experience. A bereavement reaction usually occurs after the loss of a loved person, but can also result from other losses, like the loss of a national figure or a beloved pet. The normal course of grief after bereavement occurs in 5 phases. We'll talk about them. Okay, although these should not be regarded as a rigid sequence that is passed through only once, each response to bereavement is unique to the individual and will vary greatly in severity, duration, and content. Okay, these like alarm, numbness, pinning, depression and despair, and recovery and reorganization. So about alarm, a highly stressed emotional state coupled with physiological arousal, increased heart rate and blood pressure. This is alarm. Then there would be numbness, a state of being emotionally disconnected, a form of self-protection against the acute pain of loss. Then pinning. Pinning, a state where the bereaved is constantly reminded of and preoccupied with the deceased. marked by pangs of grief and intense anxiety. Hypnagogic, hypnopompic, or pseudo hallucination and illusions of the deceased may occur. These are transient and always involve the dead person. So alarm, numbness, then pinning. After that, we reach depression and despair, a state where the bereaved have a depressed and irritable mood, thoughts of being better off dead, or that they should have died with the deceased. Anhedonia, loss of appetite and weight, insomnia, impaired concentration, and short-term memory. Then we reach recovery and reorganization, which is acceptance of loss, return of food, social and sexual appetite. Weight is regained, grief diminishes, but may return for a time of anniversaries associated with the deceased. So, hints and tips. The length of a bereavement reaction is variable and tends to be longer if the death was sudden and unexpected. Although most people will meet the criteria for a depressive episode at some stage during the grieving process, bereavement reactions are not pathological, so no psychiatric diagnosis should be made. However, patients who have been bereaved are at high risk for developing a severe depressive illness requiring treatment. DSM-5 now suggests that bereaved people meeting criteria for a depressive episode should be assessed and treated as normal. No, that's not right actually. DSM-5 suggests that bereaved people meeting criteria for a depressive episode should be treated as normal? As depressive episode? Okay. Although the shift as depression, as major depressive disorder, that's as normal, yeah. Although the shift is away from defining normal or abnormal grief reactions, both DSM-5 and the most recent draft of ICD-11 do include an option to describe extremely prolonged and intense grief causing significant functional impairment as a disorder. Okay, here we have a table that compares symptoms suggested by DSM-5 that may help to distinguish depression from bereavement. So here we have depression from bereavement. In depression, mood symptoms would be pervasively low and anhedonic, while in bereavement we are talking about feeling empty and lost, but also able to experience positive symptoms. Okay, in the variation, there would be diurnal and worse in mourning. This is in depression. In bereavement, the variation, the symptoms would be triggered by reminders of deceased. The cognition in depression would be guilt and worthlessness. In bereavement, it would be something like self-esteem intact, but preoccupied with the deceased. Suicidal thoughts would be in depression with intent to end a worthless, pointless, or unbearable existence, while in bereavement, the suicidal thought would be with intent to join the deceased or in the pain of unbearable existence. Psychotic symptoms would be mood congruent and persistent in depression, while in bereavement would be transient and transient hallucinations of the deceased. Motor function, there would be psychomotor retardation in severe cases, while in bereavement these things would be normal. So what about differential diagnosis? Following thorough exploration of the nature and severity of both the life event and the patient reaction, the diagnosis is usually clear. So, okay. Major mental illnesses are often triggered by major stressors, even if the onset symptoms is clearly linked with a stressor diagnosis of a specific major mental illness like mood disorder, psychotic disorder. So this major mental illness should be given if diagnostic criteria are met, despite the trauma itself. If a patient presents with psychiatric symptoms after a life-threatening event, always screen for features of depression as well as features of PTSD. This is because the risk for developing depression increases sixfold in the 6 months that follow a stressful event. So let's get back to the case to discuss it. Mrs. PT, a 28-year-old divorced woman, was referred to a psychiatrist. She was well and working as a cleaner until 3 months ago, when on her way to work one evening, two men cornered her at a secluded bus shelter. They pushed her to the ground and attempted to rape her, threatening to slit her throat if she screamed. The man ran off when they heard someone approaching, leaving Mrs. PT shaken but with only superficial cuts and bruises. She felt low in mood for a few days after the assault, but attempted to carry on with her job and forget what had happened. In the month that followed, Mrs. PT avoided all attempts by her family and friends to talk about the incident. She became socially withdrawn, only leaving the house to go to work. After a month, she started having nightmares about the incident and would wake up drenched in sweat. Her work colleagues noticed that she had become jumpy and quick-tempered, and that sudden movements or noises startled her. She had also started avoiding public transportation and refused to watch television for fear that something might remind her of the attack. Mrs. PT finally sought medical help after her work supervisor found her lying on the floor, seemingly in a trance, screaming, "Leave me alone," repeatedly. She recounted to her psychiatrist how she relived the attack in her mind and thought she could hear the men threatening her, just like they did during the incident. The psychiatrist noticed that Mrs. PT could not recall certain important aspects of the assault. So, Mrs. PT experienced a traumatic stressor in which she believed that her physical integrity was under immediate threat. The event was outside the range of normal human experience and would have been experienced as traumatic by most people, of course. She subsequently developed avoidance of stimuli associated with the trauma, avoided talking or thinking about it, avoided public transportation and television. She has amnesia for aspects of the trauma and social withdrawal. Later on, she showed signs of increased arousal, startle response, being jumpy and quick-tempered. Finally, Mrs. PT repetitively re-experienced the trauma through nightmares, flashbacks, and dissociation, reliving and behaving as though the trauma were occurring at that moment through mental imagery and hallucinations. All of the above suggests a diagnosis of PTSD. Now you can go to chapter 23 to read about anxiety and stress-related disorders and their management. Okay, now to the chapter summary. Chapter summary. Unpleasant responses to stressful events such as bereavement are normal and generally not pathological. Life-threatening or potentially catastrophic trauma can lead to post-traumatic stress disorder in vulnerable individuals. The three core features of PTSD are re-experiencing, avoidance, and hypervigilance. Dissociative disorders are when the normal integration of consciousness with cognition is disrupted. Dissociative disorders can disrupt motor, sensory, and memory function. A subset are now termed functional neurological disorders. Bereavement does not exclude the diagnosis of depression. So, هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.